58 weeks gestation, severe mitral stenosis need emergency Lscs. So this was the anaesthetic management. In the emergency Lscs, we have to also mention about the problem of full stomach. I uh, I don't think I heard that word full stomach problem anywhere in your presentation. Did you mention about that?
Yes, sir. I mentioned that in the beginning, sir, anesthetic and
Oh, anesthetic concern. Okay, right. So did you mention about the prevention aspect for that?
Yes, sir. Anti-aspiration prophylaxis.
Anti-aspiration prophylaxis. Okay, right. The analysis of the case is the Primi 38 weeks of gestation. So the baby maturity is guaranteed. After 36 weeks, if you deliver, you don't have to worry about the lung maturity, trying to give any steroids for that. So this baby is safe to deliver. So from that aspect, we are safe with regard to the fetal safety. The second point is this is severe mitral stenosis. So severity we do not know. So we have to extensively analyze what is the severity either by clinical features like your patient's position not able to lie flat and requiring back support, oxygen all the time, desaturating in room air. All these things are indicatives of severe mitral stenosis and whether any crackles are present, whether she is in partial failure, and what are the treatment that she is getting. All these things will have to be fully assessed. And the third thing is plan of anesthesia based on whether to deliver the baby first and do the corrective surgery for MS or together to do both in the same sitting if it is a case of very, very severe mitral stenosis. Okay. So that is the current thinking in the management of patients with severe mitral stenosis, not only to deliver and do the cesarean, but also do the corrective procedure in the same sitting. If it has been very severe preoperatively, sometimes they do it in the second trimester. Corrective surgery is done in the second trimester, either by intervention with balloon valvuloplasty or valvotomy, and mitral valve replacement can be done during the second trimester, and then the lady allowed to progress to the pregnancy by cesarean section the later date. But the current thinking, if it has progressed up to 38 weeks, then we can combine both the surgeries in the same sitting. Now, what are all the answers you should be prepared for in this Viva exam is, one is history taking with regard to onset and duration of the presenting complaints. Whether this patient now 20 years old, has she been having features of mild to mild mitral stenosis going on moderate and becoming severe even before she got married and became pregnant? Or was it diagnosed only during pregnancy and it progressed on to become severe because of the physiological changes that happen? Then, what is the present status of effort tolerance and dyspnea? What is dyspnea? What is the definition of dyspnea? These are all some of the basic medicine questions they ask you if you have a case in the exam. What is the definition of dyspnea?
It is subject to evidence of breathing difficulty, sir.
Breathing difficulty. Stridor is also a breathing difficulty. Then does it become equal to dyspnea?
Uncomfortable awareness of one's own breath.
Excellent. Uncomfortable awareness of one's own breathing. Normally, we are not at all aware whether we are breathing unless you do a vigorous exercise or you run to catch a bus or train and you exert yourself. Then you breathe in a very intense, hurried fashion where you feel the breathlessness. But normally, no one feels that breathing. Dyspnea is, I said, awareness of one. The definition of dyspnea, and that ask how many grades are there in dyspnea?
Four grades, sir.
Some of the examiners in the olden times they will get one question
Four grades.
because most of them forget what they have read in their MBBS days. 4 grades. What is the
Four
first?
grades, yes, sir.
Hmm.
Class one is no limitation of activity, no symptoms at risk, sir. And class two is a patient will be comfortable at rest, but mild physical activity causes the symptoms. And class three is patient will be comfortable at rest, but less than ordinary activity, the patient will be symptomatic. And class four is the patient will be symptomatic even at rest.
This is the dyspnea. Must know all the about the basic questions, and then history to find out the etiology. And mainly, the rheumatic fever is the cause of mitral stenosis. And I still remember my professor of medicine asking me in the class, we will say, enumerate the etiology of mitral stenosis. And we will all say so many causes. We will say number one rheumatic fever, number two rheumatic fever, number three rheumatic fever, because that is the most commonest cause for that. So questions may be completely on rheumatic fever. How do you diagnose it? What is the organism that causes rheumatic fever? What are the major and minor criteria? What is the treatment history? Whether there were recurrent attacks of rheumatic fever or not, or a single episode. So all these questions are very commonly asked. So what is the definition of rheumatic fever? We have to define rheumatic fever. What is the definition of this rheumatic fever?
Due to chronic, it is a continuous type of fever.
Is that
Continuous
louder?
types of continuous type of fever.
Continuous type of fever. Hmm.
It's due to molecular increase between the
Molecular
streptococcus.
mimicry along mechanisms. Okay? But there is a definite description for that. Have you heard of that description or definition? Rheumatic fever is defined as an acute fever, number one. It is a non-suppurative fever. It is caused by autoimmune process and it is self-limiting. Okay? So these are the four features of rheumatic fever. One, it is an acute fever. It is non-suppurative. There is no septic focus in the body. And it is an autoimmune mechanism causing the fever. And it is self-limiting. Even if you don't treat it, it may run for 4 or 5 days and it will disappear automatically. Unlike the other features where there you have a course of sepsis or infection, which will not get relieved without an antibiotic cover. This rheumatic fever will be completely gone by 5 to 6 days time, even if you don't treat it with any drugs. So these are the four features you should remember. One is it is an acute fever, it is non-suppurative, it is caused by autoimmune process, and it is self-limiting. And why this happens? What is the mechanism by which you get the rheumatic fever? What is the organism which causes this?
Beta hemolytic streptococcus.
It is caused by Streptococcus hemolyticus. Okay, and Lancefield group A Streptococcus hemolyticus. That's the full name of that. Who is Lancefield? Any idea? Mary Lancefield. The full name. Is the first lady by bacteriologist who identified this organism in the US. So Lansfield is the name of a person who classified this streptococci into various categories, and it is called Lansfield Group A hemolytic streptococci infection, which is the precursor for causing this rheumatic fever. It doesn't actually by itself cause that. What is now comes the mechanism of rheumatic fever. How does this uh, streptococcal throat or streptococcal infection, how does it lead to rheumatic fever?
It's molecular mimicry for the humans, and the streptococcal antigens will mimic the antibodies produced against the human cardiac tissues.
And to be little more clarity, we have to say that one is whenever the streptococcus invade our body produces antibodies against the antigen produced by the streptococci. And these antibodies not only kill the streptococcal invader, but the antigen has similarity in the peptide chains in the connective tissue of our body, like your joints, your heart muscles, valves. Uh, so all the connective tissues have a peptide chain which is similar to the antigen of the uh, streptococcus. So the body mistakes those normal peptide chains because they resemble the antigen of the streptococcus. They not only destroy the streptococcal antigen, but they also destroy and attack uh, the connective tissues in our body, and it first affects the joints. Okay, so arthritis or arthralgia is the first feature. Then it will go to affect the, which is the next organ, which is the target,
Heart,
heart. It will go and affect the heart. In the heart, it always first attacks the mitral valve. Why? There are four valves in the heart: mitral, aortic, pulmonary, tricuspid. Why it chooses the mitral valve as the most sought out designation for attacking? Because the shear force is the greatest there. So mitral valve shear force is the greatest, and that is prone for injury, and that is where it can easily get attacked, and that is the reason. Which is the next valve which is more prone for this attack by the antibodies produced by our body? Aortic valve. Okay? After mitral, it will be the aortic, because both are by side by side. If you see a cut section of your heart, the pictures, you will see mitral valve will be between the left atrium and left ventricle, and the aortic valve will be taking origin from the left ventricle, from the inside itself, close to the septum. So both are by side, and that is the reason why the next susceptible valve is aortic valve. Okay? So then, after attacking the heart, where will it go? It can attack the brain tissue also and produce what is the feature of a very severe rheumatic fever in the central nervous system. Scoria, Sydenham's scoria. Okay? So this arthritis, carditis, and scoria are the three important major features of rheumatic fever. Okay? So that is how this molecular mimicry produces the problems in rheumatic fever. Supposing 100 people get infected with streptococcal sore throat, will all of them develop rheumatic fever? Hmm? No, why? Why? All of us, even you and me, would have, as a child or an adolescent, we repeatedly get a sore throat, we fall sick, and if we take, normally we don't take a swab and see, but if we take a swab, it would have been streptococcal sore throat. And immediately we take azithromycin or some antibiotic and get rid of it. But why only, but some people get progress on to get rheumatic fever, and not all people get rheumatic fever because they are affected by the streptococcus, which has a rheumatogenic strain. There is a particular strain of this bacteria which is called the rheumatogenic strain, and if that strain attacks the person, that person will definitely get rheumatic fever. Others may not get rheumatic fever symptoms at all. But if a person is diagnosed with mitral stenosis and he does not have or give history of classical features of rheumatic fever like fever, arthralgia, or carditis, any of them are not present. He totally denies, no sir, I have never fallen sick like that. Then how will you know that it could be due to rheumatic fever? How could that person could have got a valvular disease caused by rheumatic fever if there are no clinical evidences of rheumatic fever? Even then, the possibility of rheumatic fever being the etiology is because it is a subclinical rheumatic fever. It does not produce the classical symptoms of 5 days fever, 7 days fever, severe arthritic pain or arthralgia or carditis. All these things may not be present. It is called the subclinical rheumatic fever, and that is the reason why this is considered as the most important cause for other reasons or other etiologies are also there, but they are quite rare. So this is the most common reason, and this is the reason why they may ask you all about the rheumatic fever in the examination. And of course, the prevention, you have said patient should have been treated with benzothine penicillin or potassium penicillin orally. And if they are allergic to penicillin, what is the drug of choice?
Erythromycin.
Erythromycin, very good. So erythromycin should be given. Okay? And the presence of any complications like congestive heart failure, atrial fibrillation is another important favorite point of examiners. So, what is atrial fibrillation? Hmm? It is an ineffective fibrillatory contraction of the atrial muscles. Okay? Mainly diagnosed by what is the clinical evidence of atrial fibrillation?
Irregular
Irregular pulse. That is the first answer. Very good. Then, what is the other method by which you can diagnose atrial fibrillation?
In ECG, there will be no clinics.
ECG, clinically I am asking. First clinical, then only ECG. ECG is very easy. You take ECG and you immediately diagnose. But in clinically, first is irregular pulse. Any other method to confirm it is atrial fibrillation? What is pulse deficit? Have you heard of pulse deficit?
The difference,
Difference between heart rate and pulse
Heart
rate.
rate is different from the pulse rate. What you feel at the periphery may be very less than what the heart rate is. So, how do you do the pulse deficit examination? Confirm. How many people you need to do this test?
Two members, sir. One to count the two
Pardon?
members we need. Two members we need, sir. We have to count the we have to calculate the pulse and count the pulse rate, and one to
One person should count the heart rate by
Yes, sir.
auscultation, another person
Auscultation,
should
yes,
count
sir.
the pulse rate by palpation, and you can find out the difference. Supposing you don't have anybody, how will you check for the pulse deficit?
we
Nowadays we have some
Same
gadgets
number.
to know the pulse rate, isn't it? Which gadget you can use?
pulse oximeter.
Pulse oximeter. If you don't have a helping hand, you put the pulse oximeter, you get the pulse rate, and you start counting the heart rate using your stethoscope. Okay. So it is not always necessary to have two pairs. It is olden days when pulse oximeter was not there. We used to do with two persons. One of our colleagues will palpate the pulse rate, will say start now and then start counting, and heart rate will be always greater than the peripheral pulse rate, and that is called the pulse deficit. These are the two important clinical findings by which you can diagnose atrial fibrillation, and confirmatory evidence can be, objective evidence can be done by getting a ECG done. Okay, what are the features of ECG in atrial fibrillation?
Absence of periods irregularly, irregular rhythm.
Absence of
Heart rate
definitive freeway
more
between
than
each QRS complex. There will be fibrillatory waves, and pulse rate will be, and heart rate will be irregularly irregular. Okay. And the QRS complex, what will happen to the QRS complex? Will it be broader or smaller or normal?
narrow QRS complex.
Narrow QRS complex will be there. Okay. So these are all the ECG findings in that. What are the patterns of atrial fibrillation?
Paroxysmal, persistent, intermittent.
Permanent, persistent, and permanent. Okay. Paroxysmal, persistent, and permanent, depending upon the duration and the mode by which it gets released. In paroxysmal, it will appear suddenly and disappear on its own without any treatment. Permanent, persistent, it will remains for a longer time, and majority of the time that also will disappear on its own. And only the permanent one which will be there all the time, and it may require treatment depending upon the need, whether the possibility, whether there is a possibility of getting a thrombus formation or not. Okay, so these are the three patterns that you have to remember. What are the complications? What are the goals of treatment of atrial fibrillation?
We have to
Three pillars. They are
restore
called
to
three
normal
pillars.
sinus rhythm. Restore
Rate
to normal
control,
sinus
First
rhythm.
is rate control.
Control,
Control
rhythm
means that rate
control,
control. Second is
thromboembolism
rhythm
prevention.
control, rhythm reversion, and
Thromboembolism prevention.
anticoagulation. Okay. How soon should you anticoagulate a patient with atrial fibrillation? Supposing it is diagnosed now and it is persisting for 24 hours or even more than that, when should a patient persisting permanent atrial fibrillation be anticoagulated?
48 hours of rest.
48 hours. If it exceeds 48 hours, you have to definitely anticoagulate. What is the drug that you can give for controlling the rate?
Beta blocker.
Beta
beta
blocker.
blockers.
Beta blocker.
Beta blocker.
So that is the rate control. For getting back to sinus rhythm, what is the method of getting back to sinus rhythm? Majority of them, when you control the rate, they may revert back to sinus rhythm automatically. But if it is not reverting, what do you have to do?
If patient is unstable, we have to go for cardioversion.
Very good. So you have to see whether patient is hemodynamically stable or unstable. If they are unstable, then definitely you have to do cardioversion. How will you give anesthesia for cardioversion? What is the difference between cardioversion and defibrillation? These are all the questions you have to expect in the exam. It is
Synchronized shocks.
Sedation,
synchronized current shock delivery. Very good. It should be synchronized with what?
R wave of the
R
complex.
wave, because that is the depolarizing wave. It is synchronized with the R wave. That any other feature?
It usually it doesn't accompany CPR, and we use low joules of
The current strength is very low. You don't have to use 200 or 300 joules like what you do for your defibrillation. What you require is only 80 to 100 joules max, and that itself will revert the rhythm back to sinus rhythm. So these are the two important features. It should synchronize with the R wave. Otherwise, if it falls on T wave, what will happen? Your shock falls on T wave. What can happen? T wave is the what does T wave signify?
Repolarization of
Repolarization. So during repolarization, if you give a shock, the rhythm may get converted to ventricular tachycardia, which will result in death. Okay, that is the reason why we have to. Of course, the machine will automatically read the ECG and deliver the shock at the time, but you must know that it should not be delivered during synchronized deep cardioversion. We should not deliver the shock during T wave. And the shock delivered, the strength, current strength is very, very low, maximum 100 to 120 joules is sufficient. And anesthesia for this,
Sedation.
sedation is enough. Any other precautions you have to take? Huh?
Impure status to be
Make sure the patient is not having a full stomach as far as possible. Okay? But be prepared for any vomiting and aspiration if the patient has taken food. Okay? So that is, these are the two important precautions you have to take while doing the cardioversion for atrial fibrillation. And with regard to anticoagulation, what is the drug of choice? Supposing you find a thrombus in the echocardiogram, you have to anticoagulate this patient. So this is another important history that you have to ask in the patient with severe mitral stenosis, whether they have had any features of atrial fibrillation and whether they are still on any anticoagulation to prevent thrombus, with which they may be coming for cesarean section also. Okay? So that is also an important history that has to be taken. So initially you can start them with the heparin. Why heparin is preferred? What is the duration of action of heparin? I think all of you would have had
6 hours,
experience
sir.
in or
6
seen
hours.
heparin being used. 4 hours.
And
So it is
fraction
a
is
short
6 hours,
half-life
sir.
and it has got a reversal agent. The form of, how can we reverse the effect of heparin? Protamine is
Protamine
available.
sulfate.
Okay. So that is the reason why heparin is preferred always for immediate treatment, because it has a short life. We can titrate the dose well, and it can be reversed if there is an excessive bleeding with protamine. So we can start with heparin, but long-term anticoagulation is done with, what is the drug? Oral drug.
Warfarin, sir.
Warfarin is given. Okay. What is warfarin? Why is it called warfarin?
It's a vitamin K antagonist.
Huh?
It's a vitamin K antagonist.
Dakumar.
It is a vitamin K antagonist, okay. But what,
It
how
is
is the name
human-
warfarin? Is it an
It is
acronym
a
for something?
human derivation.
So you find out and tell me what is the expansion for warfarin. Why it is called warfarin. Okay. So these are all the questions that you have to expect with regard to this particular problem. And the present medical management and any previous surgical intervention. Some patients with severe mitral stenosis could have had a balloon valvulotomy or valvuloplasty done, and the condition could have recurred. So that also is an important. She mentioned about previous surgical history, but this surgical intervention is also specifically mentioned, should be mentioned in the exam. And anatomy of mitral valve apparatus is another common question if you get a case of mitral stenosis. How many leaflets are there in the mitral valve? Can you describe the structure of mitral valve?
2.
It is a bicuspid valve. It is the only bicuspid valve in our heart. All others are tricuspids. Pulmonary valve also has 3 cusps. Aortic valve also has 3 cusps, and tricuspid also has 3 cusps. Only mitral has the 2 cusps. So how are these cusps held in position? Okay, I'll show you those pictures later. You will learn. And the pathophysiology of MS, all the back pressure which we have discussed, assessment of severity, investigations to help the diagnosis, hemodynamic changes. These are the time of occurrence of symptoms during pregnancy based on the severity, how MS gets worsened by physiological changes during pregnancy and labor. So she said only about the mostly hemodynamic changes, that increase in blood volume and increase in the heart rate are the two enemies for patients with mitral stenosis. That is the one which worsens the symptoms. And during labor, the labor pain will again worsen the increase the heart rate and worsen the condition. And supposing after delivery, what is the risk? How can pregnancy, mitral stenosis can become suddenly very bad after delivery of the baby?
Due to auto transfusion, sir.
Auto transfusion. After the delivery of the placenta, the uterus will contract, and how many ml of blood will go into the circulation? 500 to 700 ml can be pumped back into the circulation, and that is the main reason for patients suddenly going into pulmonary edema because of the sudden fluid overload. It cannot be tackled by the constricted valve. So how will you prevent that? Supposing you are taking a moderate mitral stenosis patient and you want to avoid this auto transfusion induced pulmonary edema, how will you be, what prophylactic or preventive treatment you can give to the patient?
Diuretics can be given.
You have to give Lasix sufficiently early before the baby is delivered. Yeah, at least 15 to 20 minutes before the baby is delivered, if you do Lasix, that will prevent this volume overload getting into the constricted valve and producing a pulmonary edema. So, diuretic therapy well in advance before the placenta is delivered. That is the step that we have to remember. The merits and demerits of RA versus GA for CS is another common question that you may ask. And combined surgery for delivery and correction of MS, the pros and cons are the latest things that you have to know, because this is being done in major centers. And it has to be well planned by what is called the pregnancy team is there with cardiac problems. So in such centers, they will tackle both the problems here. Okay? So quickly, I will go through all these. Whatever we are doing is, what are the features of rheumatic mitral stenosis is most common in females more than men, and symptoms occur 2 decades after the onset of rheumatic fever. All of you know, the age of presentation usually is between the 20s and 30s, and slowly progressing patients may even exhibit at 40s and 50s. Isolated MS will be occurring in 40% of cases. Other cases may have both MR and AR also, like other valvular diseases. And the etiology, number one etiology is rheumatic fever. The other causes are systemic lupus erythematosus, carcinoid syndrome, acute infective endocarditis, respiratory myxoma, and rarely congenital mitral stenosis at birth itself can happen, and massive annular calcification. All these things are the causes of MS. Natural history, it is a progressive lifelong disease, usually slow and stable in the early years, then progressive acceleration in the later years. 20 to 40 years latency for rheumatic fever, the symptom onset in developed countries. After symptoms, additional 10 years before disabling symptoms happen. And rheumatic fever causes, as I said, immunologically mediated inflammatory disease, which occurs due to groupious streptococcal pharyngeal infection, and it can affect the multi-system, joints, cutaneous and cutaneous tissue. And most common in children 6 to 15 years old, you get a throat infection is very common in that age. And the pathophysiology, the body produces antibodies against the antigen. The antibodies cross-react with human tissues because antigenic similarity between streptococcal components and human connective tissue molecules. This is called the molecular mimicry. There is certain amino acid sequence that is similar between the streptococcus and the human tissues. and immunologically mediated inflammation and damage of human tissues occurs, which is the reason for the heart, joint, and brain connective tissues getting affected. Clinical features, of course, it can produce as a maybe because of the Jones criteria, and evidences of how can you prove that it is a streptococcal infection in the throat? It is by a positive throat culture in 25% of the patient, and ASO titer, anti-streptococcal O titer. This estimation of the ASO titer is very, very important before you correct a valve by valvuloplasty or balloon valvotomy. Because if this persistent and streptococcal infection is the reason for the recurrence of all these split valves to close again. But if you are doing an mitral valve repair with a prosthetic valve, then this does not come into play. Whereas if you are conservatively trying to manage with a valvotomy or a valvuloplasty, then you must make sure that there is no residual ASO infection going on in the body, and that should be adequately controlled with your penicillin therapy. Okay? This is very, very important. And this is another common question they may ask you is what are the major and minor criteria and who described it? It was by one Dr. Duckett Jones. And the mnemonic you can remember for major criteria is ACEs. This two C's you can remember as one C and say ACEs and phases. And the ACEs stand for arthritis, carditis, chorea, erythema marginatum, and subcutaneous nodules. These are the major 5 criteria. And the polyarthritis, commonly swelling limited to dental erythema. Then carditis, pancarditis involving valves, pericardium, myocardium, etc. And you may get a murmur across the mitral or aortic valve. And there may be features of heart failure also. Then chorea is what is called the Sydenham's chorea, or any, what is the other name? Sydenham's disease or chorea. Any other name for that?
Huntington
We
chorea.
dance Saint Vitus dance. It is also called Saint Vitus dance. And you may have erythema marginatum, like the skin. You may have subcutaneous nodules. And for the minor criteria, you have fever. You don't have arthritis, but you have arthralgia. You have increased C-reactive protein. You may have ECG with PR prolongation, and the ESR is very high. These are the minor criteria. And so this is how you find out the confirm that it is a rheumatic fever. And these are all the clinical features. The subcutaneous nodules that you can see, the erythema marginatum, reddish patches. This is the features of Sydenham's chorea or Saint Vitus dance. And the treatment for that is during rheumatic fever, it is absolute bed rest and supportive therapy, the treatment for heart failure, the eradicating organism of anti-streptococcal therapy with benzocaine penicillin or penicillin for oral penicillin for 10 days. If they are allergic, you can give erythromycin for 10 days. And anti-inflammatory agents, polyarthritis and myocarditis, you can give aspirin, 100 milligram per kg, and you can taper it off after 4 to 6 weeks. For carditis and cardiomegaly, you can use corticosteroid 1 to 2 milligram per day for 4 to 6 weeks. So it's a prolonged treatment. It's not a easy to treat condition. You have to treat it for a long. And for preventive measures, again you continue penicillin for every 4 weeks IM and or oral penicillin twice a day for every day. And duration, how long you have to give this prophylaxis? If it is only rheumatic fever plus carditis, it should be lifelong. If it is rheumatic fever without carditis, you can give up to 5 years after the diagnosis or until the patient is 21 years, whichever is long. So if it is carditis, it has to be lifelong. But nowadays, because we are able to do MVR, then the reason for that continuation is not there. But if you are doing valvuloplasty or valvotomy, it has to be continue. That is what I told you earlier. The features of normal mitral valve, they may ask you, it is a valve area of 4 square centimeters, maybe between 4 to 6, and diastolic mitral valve flow is about 150 to 200 ml, and diastolic transvalvular pressure gradient is less than 2 millimeter. Of course, some would say 5 millimeter or less is the maximum pressure gradient. The severity, you take into 3 things into consideration: mean pressure gradient, and the pulmonary artery systolic pressure, and valve area. And nowadays, after the regular use of echocardiography, we are using another indicator called diastolic partial time. I will show you later that. So these are the 3 important things by which we assess the severity as mild, moderate, and severe. So in the severe, valve area becomes less than 1 square centimeter. The pathophysiology, what happens, we have already seen when the orifice starts reducing less than 2 centimeters. That is, when it reduces by 50%, blood flow from LA to LV propelled by elevated left atrial pressure gradient. So that is the time when it start increasing the pressure. Before that, it will dilate and try to accommodate release for the pressure. And impaired early diastolic filling will happen. This will require atrial kick to fill the blood. And when the orifice becomes less than 1, that is severe type mitral stenosis, LA pressure may go up to 25 millimeters to maintain the normal cardiac output. And this will lead on to pulmonary circulation called pulmonary hypertension. And the pressure overload constantly when it is high, LA may dilate up to 10 to 25, 12 centimeters. This distorts the depolarization pathway, leading to atrial fibrillation and loss of atrial kick and decrease in cardiac output, and it will precipitate congestive heart failure. So AF may be many times asymptomatic, but in patients with severe mitral stenosis, it may precipitate an acute congestive failure and pulmonary edema. And the changes produced by tachycardia in AF patients of varying severity. Tachycardia, AF, diastolic filling period is very much decreased, so elevated LA pressure, pulmonary congestion. Underloaded LV, decreased left ventricular end diastolic volume and diastolic pressure, scope volume gets decreased. And cardiac output in moderate MS will be at least at rest it will be normal, but it will not be sufficient during exertion. And severe, even at rest, it will not be sufficient. So patient will become. And the left ventricular systolic function is usually well preserved in patients with mitral stenosis because it is not put to any acute stress by volume overload or pressure overload. And the diastolic pressure half time, this is the one which is considered as a very important criteria for diagnosis, assessing the severity. So this is an echocardiographic finding that calculates the time in milliseconds required for peak pressure gradient across heart wall to drop to half during diastole. And it is used to estimate the mitral valve area with the formula mitral valve area is equal to 220 by PHP. That is the pressure half time. So the pressure half time is described in milliseconds. So in mild cases, it will be less than 100 milliseconds. Moderate cases, it will be 100 to 149, and in severe cases, it will be more than 150 milliseconds. So this has become a very important criteria for assessing the severity. Clinical features, of course, all of us know that dyspnea is the earliest symptom, initial symptom of mitral stenosis. So class 2 symptoms, then commonest is atrial fibrillation. And symptoms others are due to initially because there is stroke volume is also reduced, cardiac output is reduced, the VC fatigability and syncope may be the presenting symptom. But once the LA pressure start increasing, pulmonary congestion, dyspnea, orthopnea, hemoptysis, pulmonary edema, and if it is due to left atrial enlargement, you may get Ortner syndrome. I hope all of you know what is Ortner syndrome. That is the left atrium compressing the recurrent laryngeal nerve, causing hoarseness of voice, and atrial fibrillation, more common in older patients. And due to pulmonary artery hypertension, it will lead to pulmonary right ventricular hypertrophy and right heart failure also. And causes of death in mitral stenosis can be due to congestive heart failure, systemic embolization, pulmonary embolism, and infection. Physical findings, course, the malar phases, which is not common in our population, but in Western population, you can see that color change in the phases, and it may produce JVT rise ascites fetal edema, if it is the right heart failure is also there. And when you palpate, pulse may be regular. When there is no atrial fibrillation, pulse may be regular, low volume, felt in all peripheral pulses. Left parasternal key may be there when there is a right ventricular hypertrophy, and the atrial fibrillation produces a irregularly irregular pulse. Hepatomegaly will be present in right heart failure. Tapping apex beat is very characteristic. Diastolic thrill in cardiac apex in patient will largely recommend both. Auscultatory findings: loud S1, S2 closes with click, and P2 often accentuated. There may be an opening snap, which is a high pitch, readily audible expiration or just at the medial to apex followed by apex sound. And this time interval is inverse with the severity of MS. And due to forceful opening of this opening snap is due to the forceful opening of the mercury valve. And as MS progresses, mitral valve opens earlier in the ventricular diastole. And murmur, low pitch rumbling, diastolic murmur, opening snap heard best at the apex with patient in lateral 1% with well of the stethoscope. This is the classical description all of you should remember. Accentuated by mild exercise. Duration correlates with the duration of severity of mitral stenosis. It reappears or louder during atrial systole also. The additional murmurs in severe pulmonary hypertension, you can get a pansystolic murmur along the left border and louder during inspiration and diminishes in forced expiration. That is called the Carvalho sign. If the cardiac output is markedly reduced because of severe stenosis, you may have a silent MS. No murmur may also be heard. Murmur will be heard in that case. And Graham-Still murmur of pulmonary regurgitation, which is a high-pitched diastolic decrescendo flowing murmur along the left border. Sorry, this is not systolic, this is a diastolic decrescendo murmur along the left border. And complications that can happen in MS are acute left heart failure, acute pulmonary edema, pulmonary hypertension, right heart failure, atrial fibrillation, flutter, ventricular and atrial premature beats, embolic manifestation, infective endocarditis, recurrent bronchopulmonary infection, Hartner syndrome, hoarseness of voice, jaundice because of hepatomegaly and cardiac cirrhosis. And the features of pulmonary hypertension are parasternal key, palpable S2, systolic murmur over pulmonary area, systolic murmur. Systolic murmur increases on inspiration, that is Carvalho sign, and Graham-Still murmur of pulmonary regurgitation. X-ray findings, you may have the straightening of the left border. Normally, you have the two curves here that is obliterated because of the increase in the size of the left atrial appendage and the pulmonary bay. And the ECG changes in MS are broad notch T wave, and the ECG suggests left atrial enlargement, and atrial fibrillation is present about 1/3 of the patient with severe stenosis, and we may get right ventricular enlargement also in the form of or waves increase in the chest leads. And echo findings, degree of leaflet tincturing, calcification, changes in mobility are all found out by the echo finding. Calculation of mitral valve area and measurement of transcendental gradient is also done by echo. And evaluation of cardiac chamber dimension, pulmonary hypertension, left and right heart function, and other valvular diseases, and examination of left atrial appendage for the presence or absence of thrombus is a very important finding. And pulmonary hypertension is likely if the left atrial pressure is above 25 millimeters of mercury. And mitral transvalvular pressure gradient higher than 10 millimeters increases likely to cause severe mitral stenosis. And cardiac MRI is also useful in some of the cases, which will help to find out the severity, and it also finds out the thrombus level and the thrombus size. And the mitral valvular apparatus, this is what the examiner sometimes asks you. There is the annulus, that is the holding ring to which this anterior and posterior leaflet are attached, and this annulus, these leaflets are attached with the papillary muscles, and these papillary muscles are shortening into cauda tendineae. Cauda tendineae is the one which pull the valve first, and they are attached to the papillary muscles, and these muscles only make them come down and go back. Okay? So this can be ruptured in acute myocardial infarction. That may be the cause for a mitral regurgitation also. So the knowledge of this valve is important for all of us. And what is Wilkinson score? Have you heard of this? Anybody?
Yes. Use
Is to find out the degree of calcification of the mitral valve so that can decide whether it can do valvuloplasty or valvotomy by intervention balloon system. Okay, so that is the one reason why you have. So highly mobile valve with only leaflet tips restricted, then minimal thickening just below the mitral valve. Leaflets are near normal. So a single area of increased echo, I think will be there.
guide the surgical repair. Yes, sir. Yes, sir.
Not
Surgical
only, not
repair. Yes, sir.
surgical, just interventional for balloon valvuloplasty can use this and decide whether it will be amenable to that or whether you have to go for MDR. Okay, that is the main reason for this story. And the causes of ASF, this is another important etiology they may ask you, so that you can remember by it is not only mitral stenosis which produces AF, but other conditions are also. So this mnemonic arrhythmic is very easy to remember. Alcohol consumption, AST can also cause AF. Rheumatic fever by itself can cause AF. Ischemic heart disease can cause AF. Thyrotoxicosis, but hypertension and hemocentrosis, mitral valve diseases, infection, cardiomyopathy, or chronic lung infection. All these things can cause AF. So that you can remember by this knowledge. And the symptoms of AF are sometimes in patients with thyrotoxicosis or chronic lung infection may be asymptomatic. But it will become symptomatic when there is a decreased cardiac output, irregular rapid ventricular rate, loss of atrial contraction, then it will produce palpitation, dyspnea, chest pain, dizziness, and syncope. And it may produce neurological deficits like TIA or stroke, systemic embolism also can happen. The patterns, as I said, paroxysmal, persistent, long-standing persistent, and permanent AF are all the things. So paroxysmal episodes terminate spontaneously or can revert within 7 days, may recur with variable frequency. So it's all mainly because of the duration and how it is lasting and how it gets reverted. The consequences of AF are main dangerous thromboembolism, which can lead to stroke by arterial thrombus formation. It may sometimes lead to mortality also in patients with other comorbidities, and it may require hospitalization if the arrhythmia is persistent and permanent. It may cause impairment of the hemodynamics, and it produces reduced quality of life. It is an enormous burden on the society because it causes a lot of expenditure. ECG changes in AF, there is a lack of discrete T wave, fibrillatory waves rate generating between 350 and 600. Ventricular response follows no repetitive pattern by HBT. It is the QRS complex, and you have an irregular say, complex formation, and the intrinsic conduction just ranges between 90 to 130 at the nodal level. Pure complexes are normal unless AV conduction through resistance is abnormal due to causes rate-related abrasion or pre-existing bundled branch blocks that may cause a little widening of the QRS. Otherwise, in a normal person, it is a very narrow complex. So this is a normal sinus ECG, and this is a common question in the OSCE. They will give you pictures like that, so you can see the fibrillatory P waves occurring before a QRS, and then multiple numbers are there. You can see the R waves are irregularly spaced, so you can easily diagnose that. Treatment of AF is three-pillar regime. One is rate control, rhythm control, and anticoagulation. So we will not go into that deeply. And symptomatic atrial fibrillation less than 48 hours, more than 48 hours. That is the criteria for where to go for cardioversion and anticoagulation. So if you plan for cardioversion, patient should be anticoagulated before you do the cardioversion. Otherwise, you can dislodge the clot and produce a embolism. So these are all the drug therapy that you can think of, and treatment of illness based on the severity can be grade 1, usually diuretics for congestive symptoms, prophylaxis against rheumatic fever, and anticoagulation if there is a thrombus, digoxin and drugs for rate control. Grade 2 or tighter stenosis, explain treatment, severe symptoms not responding to medicine, surgery with commissurotomy or MVR or balloon valvuloplasty. So grade 2 itself you have to think of surgical intervention. And grade 3, tight stenosis with pulmonary hypertension, definitely surgical repair. Grade 4, tight mitral stenosis, pulmonary hypertension with right heart failure, surgery and treatment of right heart failure. So CHF, restriction of physical activity, and drugs, atrial fibrillation, of course, the same treatment, and anticoagulation in atrial fibrillation. These are all the additional treatments. And percutaneous valvotomy indications are progressive deterioration despite medical treatment, MS with complications, asymptomatic patient with one attack of thrombosis. That also is a very valvotomy. And when mitral valve orifice is less than 1 centimeter, this is the important treatment. What are the indications and surgical in MS are MS with MI and MS with late thrombus. Maybe valvular calcification, do a surgical repair, not just an interventional repair. And the active rheumatic tight stenosis or restenosis after an initial valvotomy, all these things require only surgical repair that can be in the form of surgical commissurotomy, valve reconstruction, or valve replacement. And this is the mnemonic that you can remember about the goals of anesthesia for MS. P stands for preload, A for afterload, C for contractility, R for rate, R for rhythm, and I for avoiding ischemia. So these are the 6 things given in the textbook of Barrage for any cardiac valvular disease or ischemic heart disease. These 6 things, if you remember, you can manage them both from exam point of view and in your future practice also. These are the things that you require. So in MS, you have to maintain adequate LV diastolic filling to optimize right heart condition. So maintain slow rate, maintain sinus rhythm, judicious fluid therapy. So for that, you have to keep a sympathomimetic drug to keep adequate CR in the form of inhaler. Avoid vasodilatation as much as possible, and avoid increasing pulmonary vascular resistance also, which can be increased by pain, hypoxemia, hypercarbia, acidosis. And right heart function you can support by inotropes, and maneuvers that may compromise life, like overflow fluid administration, should be avoided. And the technique of GA for Lscs patients with mitral stenosis. What are the medications you have to continue intraoperatively? Evaluate the fluid status and use diuretics. Check electrolytes on a day of surgery because the continuous use of diuretics may lead to hypokalemia. We told on the night of surgery, massive fluid shifts are expected in the surgery. And drug control, digoxin, beta blocker, calcium channel blockers to be continued. Watch serum potassium. Warfarin should be switch over to heparin if these patients are already on warfarin for better control. And titrate APPT to 1.5 to 2 times. Continue them post-operatively. And preoperative medication, adequate dose prevents anxiety and tachycardia, but care must be taken to avoid hypotension because of giving these drugs. And so morphine is the drug of choice for sedation. What are the advantages of using morphine? Any idea?
Relieve pulmonary edema, sir.
It's a good pulmonary vasodilator, and also it's the best drug to reduce anxiety and produce analgesia. This is the best drug, and it helps in reducing the pulmonary vascular resistance. So pulmonary edema will be avoided, and we can give promethazine, which is an antiemetic property is there, so you can combine both. You give a good sedation also. And all anticholinergics, whether atropine, glycopyrrolate, or all those things should be avoided. And anaesthetic management, induction, you have to use titrated doses, all except ketamine you can use, but etomidate will be very safe because it produces hemodynamic stability. And tipentone or midazolam also has been used. And narcotic, morphine will be the best choice, or you can go for fentanyl. Avoid propofol, direct and indirect effects on ventricular preload. Muscle relaxants that do not induce tachycardia are best drugs, or those who do not produce histamine are also very good drugs. So acrolein narcotics, acrolein should be avoided. That is not available nowadays. And rocronium is regulating and slightly increases the heart rate. But succinylcholine is good, but what it produces is it can sometimes produce histamine release, or succinylcholine apnea is another danger, which is very have to use it with care. And anesthetic management, you can use, of course, nitrous oxide is not used nowadays. You can use oxygen and air. And if you are using oxygen and air, what is the important monitoring that you have to do in pregnant patients? Any idea? What is the most what condition was diagnosed in pregnant patients undergoing cesarean section with GA?
No,
Awareness under anesthesia. That was detected only in pregnancy patients undergoing cesarean. Earlier days,
Dyspnea, yes, sir.
cesareans were done only under general anesthesia. And because you are not using any volatile anesthetic agents, patients used to be aware. Even with nitrous oxide, they could hear and they could feel what is going on. And you are avoiding narcotics also till the baby is delivered. So during that short period of induction to delivery time, many patients were aware of what is going on. That is how the awareness was detected. And that is the reason why this monitor also was found out to find out whether the depth of anesthesia is adequate or not. Okay? So nowadays, when we are using air and oxygen, even the nitrous oxide induced amnesia will not be there. So patients may be very aware if you are not using any volatile also. So midazolam pre-medication will definitely help to reduce that particular problem. Okay. So these are the things that and monitoring. If it is a very severe case, non-invasive monitoring may not be sufficient, so you may have to go for a central line with the pulmonary artery catheter if it is very, very severe. And this pulmonary artery catheters or the central line will help in another important uh, therapy. Sometimes we may need ECMO also these patients. If they become severely congested lung and hypoxic, then they may require a xenovenous ECMO to oxygenate these patients. So the central line will also help in the institution of ECMO therapy for them. And the anesthetic management right heart failure, pulmonary edema is to be avoided with the post-op by adequate pain relief. And sometimes patients with severe MS and lung congestion may require a period of post-op mechanical ventilation also. And these are all this particular picture. Sometimes we may get it in the OSCE where there is a reduced volume and pressure. So stroke volume and cardiac output are relatively fixed and low. So this is the normal pressure volume loop. If it is less than 50% of that, that is the classical mitral stenosis thing. These are all the series of changes that will happen in pregnancy because of the mitral valve stenosis. And anticoagulation during pregnancy, this is another common question. If a patient has to be heparinized in the antenatal period, you can give heparin for up to 12 weeks in the antepartum period. It is the first trimester, you can give heparin with the APTT maintained between 1.5 to 2.5. Then we can go switch over to warfarin from 12 to 36 weeks because warfarin has got some uh, uh, effect on the fetus, growing fetus. So you have to avoid warfarin during the first trimester, and you can start it from the 12 weeks when organogenesis is over, and then up to 36 weeks you can give. And because of its prolonged duration of action, that is, even if you withdraw that, it will have effect up to 3 days. So you have to stop it at 33 weeks and again switch over to heparin if it is required after 36 weeks. So first is 12 weeks heparin, 12 to 36 weeks warfarin, again after 36 weeks heparin. This is how the schedule for anticoagulation. There is a score called corporate score and the risk involved, and there if the patient had a prior cardiac event like heart failure, pulmonary edema, transient ischemic attack or stroke, and functional dyspnea class more than 2, low oxygen saturation and room air less than 90, has reduced ventricular function with ejection fraction less than 40, and left heart obstruction like aortic valve or peak ventricular outflow gradient is more than 30, mitral valve area less than 2. So these 4 criteria, if depending upon their presence, you get the zero risk if it is 5%. One risk, you have 27% mortality, and more than 2 of this risk, you have 75% mortality. You can use this scoring to assess the mortality and decide on how invasive your monitoring should be and what the treatment for correcting the stenosis by simultaneous surgery to correct that also should be thought of. How do you use regional anesthesia in MS patients for both normal delivery as well as operative delivery? So what we are the question says it's an emergency Lscs, but if the examiner asks, supposing everything is all right and the patient wants a normal vaginal delivery, then you have to give a good labor analgesia to prevent the pain and the tachycardia. And it should be because you are giving a very low concentration, it will not produce a gross sympathetic blockade, and you are not worried about the hypotension. So it can be managed with a very low concentration local anesthetic, which combined with a low dose of fentanyl can be definitely tried for normal delivery also if there is no emergency indication. And Regional anesthesia, slow titrated epidural with a catheter or combined spinal epidural with a very low intrathecal volume combined with a narcotic and then top up with an epidural. These are the only two central neuraxial blockades which are safest in these patients. And it avoids dangerous tachycardia, avoids high blood pressure surges caused by general anesthesia, especially when you try to do a laryngoscopy and intubation, you are likely to cause a very high blood pressure and tachycardia. And of course, another point you have to remember, if you are doing under GA, you have to use adequate doses of short-acting beta blocker like esmolol before you do the laryngoscopy and intubation. And of course, pre-oxygenation, you also mentioned, is very, very important and to prevent. And you can, nowadays, facilities are there to prolong the oxygenation and increase the safe apnea period. Even if you anticipate difficult airway, you have to have all facilities for prolonging the safe apnea period with continuous oxygen flow, drive, and all these things which you have to be aware of. And advantages of regional anesthesia, you have a conscious patient, you are avoiding the airway stress, the hemodynamic stability can be maintained by slow titrated block, and it produces excellent analgesia, and this analgesia can be continued in the post-op period also. Okay? So the various categories of cesarean section is category 1, category 2, category 3, 4, which I think I have told in the earlier class. Category 1 is immediate life-threatening threat to life of the mother or the baby, and it should be baby should be delivered within 13 minutes when there is an announcement that it's a category 1 cesarean section. Category 2, maternal or fetal compromise is there, but there is no immediate life threat. So you have time to resuscitation, so it can take some more time. And grade 3, needing early delivery, but no maternal or fetal compromise. Grade 4 is what we now in our practice commonly call as elective cesarean section. Whereas in the Western countries, they say it is category 4. All other three in our classification is emergency cesarean section. And goals for this, of course, low heart rate, sinus rhythm, avoidance of aortic caval compression in the pregnant woman, and you must maintain adequate venous return, maintain adequate SPR, and prevention of pain, hypoxia, hypercarbia, acidosis, which may increase the pulmonary vascular resistance. These are all the goals in the management of a pregnant woman coming with mitral stenosis. And these are all some of the things. So cardiography. So metoprolol, propranolol, diltiazem are all safe drugs for use during pregnancy. Diuretics, furosemide may be used to decrease pulmonary venous congestion, but they have to be given to avoid over-diuresis. Mitral valvuloplasty can also be considered in severely symptomatic patients who are refractory to medical management with a favorable anatomy like not much of calcification in the leaflets. And surgical intervention is required during pregnancy. Intervention during the second trimester is ideal after organogenesis is complete. Prior to fetal viability, around 20 to 22 weeks is generally recommended to maximize fetal outcomes. So these are all. And this was a case scenario I got it in an article. There was a clinical examination revealed a diastolic murmur with maximum the intercostal space. Transthoracic echo showed evidence of severe mitral stenosis with a pressure of 32 millimeters in the orifice of 0.6, which indicates the severe mitral stenosis. The case is discussed with the pregnancy heart team in that hospital, which consists of cardiologists, physician, neonatologist, cardiac anesthesiologist, and they had a plan A where beta receptor antagonism with bisoprolol continued on the day of surgery. Induction of GA with fentanyl, thiopentone, and rocuronine. maintained with fluorine up to 0.6 max, and avoidance of maternal tachycardia, maintenance of preload, afterload, and continuous cardiac measurement with pulse contour analysis. And plan B was in case of hemodynamic instability, rapid initiation of extracorporeal life support with or without PMC, is planned metroconstructomy. The patient shifted to hybrid operating room, hemodynamically stable, normal sinus rhythm with heart rate of 55 beats per minute and a blood pressure of 105/69. Invasive catheters inserted under local anesthesia, that is radial arteries and catheter, and introduced a sheath for rapid initiation of veno-arterial extracorporeal membrane oxygenation, as well as an introduced sheath for PMC, and started infusion of norepinephrine titrated to the target normal magnitude. High normal systemic vascular resistance was maintained to compensate for reduction in vascular resistance and myocardial contractility as per induction of PA. And so this is how the case was managed. So these are all the things that will be useful for your exam purpose. Any questions or any doubts on that?
Yes, sir, it was a very useful presentation.
Okay.
Yes, sir.
Thank you. And,
Thank you, sir.